Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. Welcome to today's discussion. We've entitled it 2021 Compliance Update, MIPS and Time-Based Coding. My name is Brett Papke. I'm the Director of Eye Care Professional Services with RevolutionEHR. Happily joined by my colleagues Marnie Anderson, Tracy Steenis. Marnie and Tracy will be answering questions live in the questions area that go to webinar panel, so please feel free to type them out there at any point. Any that we don't get to through the course of the discussion today, we will address through email after the fact. A couple of disclaimers as we get started. The information that we're discussing in this presentation is official, and everything is accurate to the best of our understanding at the time of the presentation. That means if you happen to be watching this in recorded fashion in July of next year, there's a chance that there could be some clarifications from CMS and other entities that may change the information slightly. Third, the information doesn't change what's in place for 2020. I know there's only a couple of weeks left, but what we're talking about here is forward-looking information for 2021. Remember that it doesn't change the things that you need to do in 2020. What we're going to cover, unfortunately I used the word tonight there, we'll say this afternoon. We broke down the information into two parts. One, we'll talk about the changes for MIPS in 2021. We'll define what MIPS is, talk about if you need to participate, why you might want to, why you might not want to. Talk about what's new. Then we'll jump into time-based coding. We'll discuss the coding changes that are taking effect next year, and we'll illustrate those associated concepts wherever possible. We anticipate probably about 45 minutes, maybe 20 to 25 minutes for each section. But with that in mind, let's jump into it to be as respectful as possible for your time. We'll start with the Merit-Based Incentive Payment System, or MIPS 2021. We'll talk through the key ideas here on this single slide. We'll spell them out, and then we'll dive in a little bit deeper in the subsequent slides. Number one, there's minimal year-over-year change finalized for the Merit-Based Incentive Payment System in 2021. A lot of that has to do with allowing us stability moving forward. CMS knows we've been troubled by and challenged by COVID-19. There's been some burden on our practices, so they want to keep the burden that the program puts on us as limited as possible. There are no changes to eligibility determinations. We will talk through that more in depth. There's an increase in the performance threshold. That's the value that Medicare compares your MIPS final score to. So said differently, there's a little bit of an increased expectation on us in practice. There's a small shift in the weighting of two of the performance categories and how they contribute to your final score. There's no change to performance period lengths, meaning the amount of time that you're expected to participate in each performance category is the same as it is in 2020. There's a concept out there that's been talked about for a little while known as MVPs, or MIPS value pathways, that's been delayed until 2022, and very importantly, that would be at the earliest. We will talk through, even though this doesn't apply in 2021, we'll talk through the concept just so you can get a feel for why this idea is out there and what it aims to do. And then finally, extreme and uncontrollable circumstances exception. That's going to continue to be available in 2021 for those practices who believe that they've been impacted by COVID-19. And it's impacted their performance or their participation in MIPS. Through this exception, you have the ability to request reweighting of one or more of the performance categories. So one of the first questions that often gets asked when we talk about MIPS is why? Why do we care about this? And the answer is that it impacts the Medicare physician fee schedule. Based on how you do, you could see more or less for a given procedure than another provider. Let me rephrase that and say another optometrist in your community. As an example, if you have 5 optometrists in your community, each performs a visual field, they could each be reimbursed a slightly different amount based on how they do in this program. There's no longer a formula out there that's going to modify every doctor's reimbursements by the same amount each year. Now, the way MIPS works is it assigns you a score based on how you do in each of these 4 performance categories. You can see that each of them contains a set percentage of how it contributes to your final score. And your final score is on a scale of 0 to 100. The higher it is, the better, because your score, as we mentioned earlier, gets compared to a Medicare-defined value known as the performance threshold. If your score happens to be higher than that performance threshold and you're eligible for MIPS, then you'll see your reimbursements going up 2 years later. And when we're talking about 2021 here, we're talking about impacting reimbursements in the 2023 payment year. On the flip side, if your score happens to be below that Medicare defined value, then you'll actually see your reimbursements going down. When we think about magnitude, it can be up to 9% in either direction. So sometimes people will look at that and say, well, I know that the amount of Medicare volume I do isn't all that much, so the burden of participation is probably going to outweigh any potential upward reimbursement revision that I would see, so I'm out. On the flip side, some people might say, Well, I want to be paid the most I can for any service that I provide. So I'm going to participate in this program and try to take advantage of it. Whatever approach you take, our aim in a presentation like this is just to at least discuss the facts so you can make an educated decision about the path you'd like to take. Illustration-wise, if we try to illustrate those concepts, we have our fictitious doctor, Dr. Smith here, and she scored, we're going to say 77. And again, she got that 77 based on the number of points that she collected from these various performance categories. The performance threshold is the value that her score is compared to. That will be 60 next year. So those of you who've participated before and participating at present, you know that in the current year, that value is 45. The year before it was 30, the year before that it was 15, and it was 3 before that. So there's been a steady ramp up in expectations. But we'll see it at 60 next year, 77 for Dr. Smith. Because Dr. Smith is MIPS eligible and she scored above that performance threshold, she's going to see her reimbursements go up in 2023. The actual amount that her reimbursements will go up will depend on how everybody else in the program did. And that is to say it's a budget neutral program and that the people who receive upward reimbursement revision do so at the expense of the people who are penalized. More on that in a sec. There's also bonus money out there. Specifically, there's a pool of $500 million to reward those providers who achieve what Medicare calls exceptional performance, and that would be defined next year as 85 or above. In this example, Dr. Smith would see her reimbursements going up because she exceeded the standard performance threshold, but they aren't going to go up as much as they could have if she had scored in this bonus range. So the ideal is to score 85 or above because that's where the largest upward reimbursement revision would occur. Now, when we look at threshold trends over time, I hinted at this a second ago. When we look at performance threshold, the value that your score is compared to, Medicare has been very clear throughout that they intend for this to go up over time as they ramp up expectations. We're going to see in 2022, there's a little star there because that is the first year that the comparative value is going to be set based on the average or the median figure of everybody who's participating in the merit-based incentive payment system. So that's projected to be 74. But for 2021, it will actually be 60. When we look at the bonus, that's actually gone up over time as well. And when you look at the associated potential reimbursement revision, that too has gone up. So I think it's natural to look at a progression like this and start to get worried and say, oh no, what am I going to do as this gets harder? It's more likely that I'm going to be penalized. But the way we choose to think about it and talk about it is that increasing thresholds actually equals increasing opportunity. You know, if we were to jump back to 2017 for a second, one of the big complaints from people that participated was the people who scored perfectly didn't achieve anywhere near what they thought they were going to in terms of upward reimbursement revision. In fact, in 2017, if someone scored 100, so they have a perfect MIPS score, their upward reimbursement revision for 2019 was 1.88%. And the reason for that is because the requirements of the program were so easy. Basically, we can't have our cake and eat it too. If we want the program to be easy, then we need to understand that not too many people are going to be penalized. And if not too many people are penalized, there just isn't enough money to fund those people fully that are due upward reimbursement revision. So again, increasing thresholds means more people will see penalties, but the people that are seeing penalties doesn't need to be you. If you understand what needs to be done and it makes sense for your practice, then it actually represents increasing opportunity on the financial front. Eligibility is a big topic in MIPS because not every clinician is required to participate. Eligibility requirements are exactly the same as they were in 2020. There's 3 classes or groups of providers who are not expected to report, or let me rephrase that and say not required. The first would be if you're newly eligible to provide Part B services in a given year. In 2021, let's say, in this example. So if I first get credentialed next year, I don't have MIPS reporting requirements. The second is if I'm moving down the other arm of the quality payment program known as Advanced Alternative Payment Models. That is a distinct path from MIPS. So if you're moving down that APM path, you don't have MIPS reporting requirements. The big one on here that gets the most discussion as far as optometry goes is the low volume threshold. What the low volume threshold has said is that if you do below $90,000 in Part B allowable charges, or below 200 Part B beneficiaries that you've cared for, or below 200 Part B covered professional services during 2 very specific windows of time, then you don't have to participate. You don't have reporting requirements. Medicare wouldn't be expecting anything from you. The challenge there, though, is remember that we said that MIPS is how reimbursements get modified moving forward. So if a large group of providers is actually excluded from participation, based on this low volume threshold criteria, it leaves a lot of people on the outside looking in and wondering how they can find a way into the program to see their reimbursements change. So based on stakeholder feedback, back in 2019, Medicare finally added the ability to opt in. And what that means is to be absolutely required to participate, you need to exceed all three of the values that you're seeing here for the low volume threshold. You need to do more than $90,000 in Part B allowable charges. You need to see more than 200 Part B beneficiaries. And of course, through that, you would provide more than 200 covered professional services. But if you can't do all those, now you have the ability, if you can clear one or two of these hurdles, you have the ability to raise your hand and say, yes, I understand I'm not traditionally eligible, but I want to be part of this program because I want a chance to see my reimbursements increase. So said again, the only way you will be absolutely required is if you exceed all three of those low volume threshold criteria. If you don't exceed all three, but you can exceed one or two, then you have the ability to opt in if you would like. The gold standard tool for eligibility determinations is actually the Quality Payment Program website at qpp.cms.gov. You can see in the screenshot that we have here, if you work under the MIPS tab, you'll be able to check your participation status and you'll plug your NPI number into that field and it'll return your eligibility for each tax identification number that your NPI is associated to. And that is to say that if you see patients in multiple locations, multiple businesses, each of those business entities needs to be considered independently. So you may have different eligibilities in different locations. Ultimately, 90% of optometrists, when they look just at the individual level, meaning they're evaluated only on their own merits, they will see themselves exempt. Now, that doesn't include people that could potentially choose that path of opting in that we talked about a second ago. And it doesn't include group reporting, which is where you pool all the data of all the doctors in the practice together for eligibility determination. So if I say that differently, about 90% of us, when we look at this, we'll see that we aren't absolutely required to participate. But many more of us can actually find a way in through voluntarily opting in or group reporting if we find that MIPS is something we want to do in our practices. So with that as background, let's step through each of the performance categories. We'll start with promoting interoperability. And believe it or not, this is the only one that absolutely requires your use of an EHR. So if you're watching this or attending this and you're on paper, that's perfectly okay. You can participate in MIPS that way. The only difference is you would miss out on this 25% sliver or piece of the pie. This is really the revised version of meaningful use from the days of old. You remember back then you had, depending on the stage you were in, you had up to 25 different objectives and measures that you needed to track. And over time, that's been scaled back significantly to just focus on the things that relate to promoting interoperability between EHR systems. And if we look at the changes for 2021, we're going to see that they're actually very minimal. The first is related to the prescription drug monitoring program, and we can see that right here. It's actually one of the well, I shouldn't say one of, it is an optional measure of e-prescribing. I am not certain how to talk to it in this presentation beyond saying the idea that it only applies to those providers who may be writing prescriptions for Schedule II medications. The concept is if you are writing a prescription for a Schedule II medication, then you would check your state's prescription drug monitoring program during that process to obtain the patient's opioid history to make sure that those types of medications aren't being overprescribed. So if you are not in a state that allows that, or if you are in a state and you don't write Schedule II medications, that won't apply to you. Number two, the receive and incorporate measure of health information exchange, which we can see right here. Used to be in the present day, it's named receive and incorporate. There's just a little housekeeping here and changing incorporate to reconcile to formally recognize that doctors can actually use some clinical decision making in determining the information that they want to add to their record. It's not a passive process where they're forced to put everything in. Finally, and this is the big one, in terms of change, is there would be an optional measure of health information exchange next year known as bidirectional exchange. So your path for health information exchange in 2021 would have you doing either the two traditional approaches, these two traditional measures involving supporting electronic referral loops, or if you happen to be involved with a health information exchange as an entity, and you can think of that as a third party that facilitates the exchange of information between doctors and practices. If you happen to be engaged with one of those entities and you're commonly sharing information back and forth, then this would be a path for you. But if you're not engaged in one of those, then you will be doing the traditional approach. Now, there'll probably be some questions about that, so if there are, feel free. We'll give you some avenues to send questions after the discussion if you'd like. But it's a fairly big topic to cover in a session that we're trying to be respectful of everyone's time. So let me know if there are questions later on. If we summarize promoting interoperability, though, minimum any 90 consecutive day performance period. That is consistent with what it's been since promoting interoperability has been around. But if we think back further, back to the days of meaningful use, there was a point in time when there was a 365-day performance period, actually called reporting periods back then. The thinking was at some point Medicare was going to go back to a 365-day period, but they formalized in this 2021 final rule that it will officially be 90 days forevermore. So we don't have to worry about that anymore. It's going to continue to be flexible to allow us to choose what makes the most sense for us. For each of the 6 measures that are included here, you have to report success at least one time or qualify for an exclusion. And on the exclusion front, there's exclusions available for everything except for providing patients electronic access to their health information. A lot of times we think of that as the PHR measure, the patient portal measure, where we have to make sure that the patient's information is there for them and that they have the ability to access it if they'd like. There also will not be an exclusion for that optional measure of health information exchange we talked about. But at the same time, it shouldn't matter that there's no exception there because it's not something you would choose to do if you're not involved with a health information exchange. You still need to complete a security risk analysis at some point during the year. It can be outside your 90-day performance period, before or after, just as long as it's done during the 2021 calendar year. And for the sake of perspective, RevolutionEHR provides a MIPS PI scorecard to help practices analyze their performance in real time. And this is what that scorecard looks like. If you're using a different system, I'm sure your system has one, but just to give you a point of reference for what's in ours, this scorecard can be customized by provider or group practice. You can customize it to the tax identification number that you're interested in reporting on. You can customize the date range. The system will provide the metrics automatically for those measures. And then you can actually dive into the individual measures and see the patients that are included in the numerator and denominator. Next up is quality. Quality is worth 40%, may end up being worth more than that for a lot of optometrists. We'll talk about why in a second. And there aren't really a ton of changes on the quality front to talk about, but I did want to mention this measure benchmark idea. Back in the proposed rule that came out in the first part of the year, actually when I say first part now, I wonder if that's actually true. I'm thinking like might have even been July at the point that the proposed rule came out. But Medicare expressed concerns surrounding their ability to create benchmarks. So when we think about what a benchmark is within the context of quality reporting, especially within this category, a benchmark is performance data from how all doctors did on a given measure 2 years earlier. Okay, so when we think about the 2021 performance year, that means benchmarks would need to come from 2019. And many of us may remember that Medicare added flexibility for 2019 courtesy of COVID-19. Now we know COVID-19 didn't impact us in 2019, but it did start to impact practices in the first quarter of 2020, and that's when 2019 data is submitted to Medicare. So through that, Medicare said, you know what, if this is impacting you and we required you to participate, if you can't get data submitted to us, that's okay. We won't penalize you for that. So Medicare was worried that a lot of practices would actually take that pass, and by doing that they wouldn't have a broad set of data to create benchmarks from. Now, thankfully, between the time of that proposed rule and the final rule, they've had the chance to analyze the data and see that they do have a broad set of data that they feel accurately reflects the performance of people participating in the various measures. So our benchmark data for the 2021 performance year will be based on 2019. Now, why does this matter to us? Because if that wasn't the case, Medicare was going to provide benchmarks after the 2021 year, which means we wouldn't be able to get a true reflection of our performance or that true insight into performance until it was too late to actually make modifications. Okay, so that's the key there. In this category overall, it's a full calendar year of performance data that needs to be submitted. Many of the same eye-specific measures that you may be familiar with will be around. Benchmarks from the 2019 performance period are going to be used, as we just mentioned. And again, on the scorecard front, your system may have a scorecard that helps you in this area. Again, ours looks very similar in that you can customize it based on an individual provider or the group. You can customize your date range if you wanted to analyze a shorter time frame to see trends that are happening over the shorter term. And you can customize it to the business entity or the tax identification number if you have multiples that extend across your practice. The nice thing about the quality scorecard is that it takes into consideration all the official scoring logic from Medicare. So those 2019 benchmarks will be built directly into this scorecard so that our users can get a true idea of what their quality composite score. It takes into consideration all of that scoring logic so that the doctors using our system don't have to. Finally, improvement activities and costs. These are fairly straightforward to talk about. On the improvement activities front, it's easy because there's a good chance that even if you've never explored this topic before, that you're already doing improvement activities in your practice or things that Medicare would consider to be improvement activities. An example would be making ourselves available to our patients outside of normal business hours. I think that's something that a lot of us just do because we know it's good for our patients and good for our practices. But Medicare would reward you for that in terms of giving you credit for an improvement activity. Ultimately, these activities, of which there's more than 100 that you get to choose from, they are defined as things that Medicare believes are going to lead to improved patient outcomes if we do them. Now, most require you to participate in them for at least 90 days during the calendar year or during the performance year. Some of them have slightly different time requirements on them. And then there's minor changes to that menu of 100 plus activities. And most of those changes are in the descriptions. What I would encourage you to do if you want to explore this topic a little bit is head to that quality payment program website that we talked about before, qpp.cms.gov. There's a measure lookup tool in there where you can actually filter all 100 plus measures or activities based on a particular keyword. So if I wanted to see just the improvement activities that were related to referrals, I can do that. A long-winded way of me saying a lot of people who are participating in MIPS are going to see full credit in that performance category pretty easily. Finally, on the cost front, there's a full calendar year performance data required here. However, you don't need to physically submit anything. Okay. Medicare creates measures for the cost performance category based on the normal claims that you submit to be reimbursed for care. So because of that, because you don't need to submit anything, there's also no scorecards that you can monitor to track performance. So that lends itself to this statement of just provide the great care that you always do. If you're doing what's necessary for your patients each and every day, no more and no less, then the cost category is really going to play out the way it's going to play out. You'll be a whole lot better served by focusing your attention on the things that you can control, like promoting interoperability, quality, and improvement activities. Now, finally, MIPS value pathways, or MVPs. To understand what an MVP is and what Medicare is thinking here, we need to think back to the early days of quality reporting in general. And one of the things that sort of fell by the wayside was the concept of evaluating providers based on their performance. One of the goals of these programs was to make it easier for patients to actually select a provider. They could look at the providers in their community of a given specialty and see, oh, well, this provider got a score of 90 and this one got a score of 70. So maybe I want to see the provider who saw 90. The problem with that concept, other than the fact that a lot of patients probably haven't started to use that type of philosophy, is that, for example, if we take the quality performance category, there's over 200 measures in the quality performance category. As an optometrist, I could report 6 measures of my choosing. Nobody tells me the 6 that I need to report. Now, obviously, it makes sense for me to report eye-related ones, but I don't have to. I could report anything. You, as an optometrist, could report an entirely 6 different measures. The optometrist down the street from you could do another different 6. So if a patient tries to compare those 3 providers and they're all reporting on different measures, well, then it's not a real true comparison. It's not what we call an apples to apples comparison. Plus, with over 200 measures to pick from, it lends itself to some pretty significant confusion on the part of clinicians because they don't know which measures they should report. So MVPs are designed to be a solution to both of those problems. By defining a set of measures and activities that a clinician of a given specialty would report on, it provides patients with that apples to apples comparison, but it also, removes burden from the providers in terms of deciding what they need to report. Now, this will very likely be implemented as optional when it comes about, so you'll have the choice of doing an MVP or traditional MIPS, and it would likely move to being required over time. And we won't see this in 2021. I just thought it was important, since it had been proposed to be in 2021 at various points in the past, to actually get a little bit of a feel for where Medicare is headed. It's delayed until 2022 at the earliest, and many are thinking it'll be a little bit longer than that based on the feedback that's going to be required to create these pathways. Now, just as an example, and I'll reiterate that this is a pure example, let's look at what an ophthalmology measure said. or a MVP could look like. And you'll see if we look at the quality and improvement activities categories here, rather than there needing to be a list of 200 that I need to choose from, Medicare is actually defining the specific measures that I would be expected to report on. Similar in improvement activities, there isn't a list of 100. They are saying these are the 2 that you're going to do and report on. So that's the background information. Just to give you some idea of resources that RevolutionEHR customers have access to, we host a bunch of recorded webinars and documents and videos on how the measures are achieved in our MIPS Resource Center. We have a help menu in the application that sends questions directly to our quality reporting team. We also have a community on Facebook where practices can share their approaches to quality reporting and share how they've made things happen in their practices. We also have a partnership solution that partners with practices to help them offload as much of the work as possible, from score optimization, which, as you can imagine, if that score is going to be what's impacting your reimbursements, we need to make sure that it's accurately reflecting the things that you're doing in practice, to data submission, where our team would actually submit the data for the practice so they don't have to worry about portal credentials and access and knowing how to generate the files and all that stuff. And then finally, audit protection. Our team, if a practice was ever selected for an audit, our team would actually front the entire response. Very happy to say that we are 100% successful in that front. No RevAspire doctors ever needed to return money to the government as a result of a failed audit. So those are just some of the resources that RevolutionEHR customers have access to. But if we summarize MIPS, there's minimal year-over-year change, as we talked about. There's no change to eligibility determinations. There's a little bit of an increase in the expectations of participation in the form of a higher performance threshold. The cost and quality performance category weighting shifts a little bit, but as we said, a lot of optometrists don't end up seeing a contribution from the cost performance category at this point in time, and those points end up going back to the quality performance category, which is why we said focus on the categories that you can actually control. There's no change in performance period lengths. We talked about the finalization of the idea of a 90-day performance period forevermore for promoting interoperability. We talked through the concepts of MVPs and what they're designed to do moving forward. And we also talked about the extreme and uncontrollable circumstances exception. I don't believe I made the point, though, that when you follow the extreme and uncontrollable circumstances exception, if you choose to request reweighting of all 4 performance categories down to 0, it is true you would not be penalized, but at the same time, you also would not see upward reimbursement revision in the year 2023 if you had achieved performance to get to that point. I hope that idea makes sense. Basically, if you claim that exception, you are treated as if you never had reporting requirements in the first place. So that may be a good point to take a quick breather, Tracy and Marnie, and see if there are any questions out there related to the MIPS part of things.
Thanks, Brett. It is very quiet on the question front so far. So no MIPS related questions for you as of right now.
Okay, cool. We'll move on. Either that or everybody fell asleep by the MIPS stuff. But time-based coding could wake people up, probably. It's a big topic because it's a brand new idea in 2021. Relates to the evaluation and management code set. So remember, when we talk evaluation and management code set, we're talking about those 99,000 series office visits. What we're not talking about is the general ophthalmological services, your 92,000s, like your 92004, 92004, 92002, 92012. Those are your general ophthalmological service. We're talking about the 99,000s here. So back in November of 2019, modifications were introduced to those evaluation management codes, and they were predominantly designed to reduce burden. Basically, the powers that be recognized that a lot of doctors were adding unnecessary documentation or being forced to do certain things documentation and coding-wise simply to support various code levels. So the modifications were really designed to decrease things that were unnecessary or could be deemed not related to the care of the patient, and we're simply supporting a higher code level. The modifications are going to take effect on January 1st of next year. And they represent the first real changes in coding in over 25 years. You know, if you've ever looked at the documentation guidelines for the evaluation management services, you know that the dates on those, depending on the version you look at, was either 1995 or 1997. So it was been a fairly long time since these things have changed. And we know that in the present day, if we're going to code using a 99,000 series office visit, there are 2 approaches. A is the approach that most people know, and that's consideration of case history, physical exam, and medical decision-making, and how those all interrelate determines the final visit code. The other approach that doesn't get as much publicity is time, and the reason it doesn't get as much publicity is because it's only relevant when counseling and care coordination takes up more than 50% of the visit. And we don't tend to see that a lot in primary eye care, so that's why people tend to be more familiar with that A approach. But regardless, moving forward, everything's changing. Next year, if you choose to use a 99,000 series office visit code, you will do that based on medical decision making alone or total professional time. And trust that we're going to focus on total professional time in a second. We'll define it fully. But if we look back at medical decision making for a second, you'll notice that there's no reference to case history and physical exam. That is not the AMA saying, you know what, people don't need to do a case history and exam anymore. It's just tell us about your medical decision making. You are instructed and recommended to perform the case history and physical exam as you see clinically and medically appropriate. However, when you go to choose your final visit code, it will only consider medical decision making. Okay, so the rules there and the guidance is actually fairly similar to the way it's been in the past. There's some updated descriptions to help people understand the various levels of MDM. So let's focus more on total professional time because it is the new concept. And when we do that, there's naturally going to be some questions about the intervals of time and how those relate to the various codes. So what we did is we broke two tables out, one for new patients, one for established patients. And the first thing that'll probably jump out here is that level 1 coding is not going to be possible by time. On the new patient front, it's because the level 1 code's been deleted. On the established patient front, it's because the doctor typically isn't involved. And if the doctor's not involved, then there's no professional time to speak of. The next thing that you may see is level 2 starts at 15 minutes for a new patient and 10 for an established. So a question that'll normally pop up is, well, what if my encounter only utilized 8 minutes of total professional time? Well, the answer in that scenario would be you wouldn't code that visit based on total professional time. If you're going to stick with the 99,000s, you'd have to use medical decision making, or you'd have to consider the general ophthalmological services, the 92,000s, if the visit qualified for it. Similar concept on the higher end, where there's an upper limit here of 74 on the new patient side and 54 on the established side. So the question will normally come up, well, what if there's more than 74 minutes of total professional time? Well, thankfully, CPT introduced a new code for 2021. That is 99417 to account for 15-minute blocks of time over 74. And as much as I don't want to introduce confusion to this, don't shoot the messenger, but there is a little bit of a wrinkle in typical regulatory fashion. Between the time of the proposed rule and the final rule, CMS decided that they didn't like the description of 99417. So in return, they created their own HCPCS code for Medicare, and that is G22 point, not G22 point, it is G2212. So what does this mean for us seeing patients? It means that if you're working with a Medicare patient and you have an encounter on a new patient that goes beyond 74 minutes, then you will use code G2212. Now, if you're working outside of Medicare, we're sort of going to need to keep our ears to the streets and see what our individual providers want, because both of these will be valid codes. Either way, the philosophy is the same. They're going to account for 15-minute blocks of time over that upper end if needed. So if I provided an encounter that took 70 minutes of total professional time, that would be coded as level 5. If I got up into the 80-minute range, now it's coded as level 5 plus 1 unit of the prolonged services code. If I get up into 100 minutes, now I'm into the second block of extra 15 minutes. So now I can add 2 units of that prolonged services code. And this can go out in theoretically in infinity. However, you shouldn't have an encounter that takes infinity because you probably wouldn't be here for this discussion today. But I think you get what I'm saying. In the interest of space, we stopped at 2 units, but it could go out as long as it needed to be. Similar concept on the established patient side, except the time interval is a little bit different, right? The upper end is 54 instead of 74 minutes. So the big question from there is, okay, well, I sort of get that idea. What is total professional time? What can be included there? So this was pulled directly from the way it will appear in CPT, and it is both the face-to-face and non-face-to-face time personally spent by the physician and or other qualified healthcare professional on the day of the encounter. It includes time and activities that require the physician or other qualified healthcare professional, and does not include time and activities that are normally performed by clinical staff. And I think that parenthetical is really important to this discussion, because I think when we look at that term, other qualified healthcare professional, we may inappropriately assume that that's our technician. And it's important to recognize that that's not the case. Other qualified healthcare professional is actually a term meant to encapsulate non-physician types of providers, or providers who don't fit the description of physician, but are still independently capable of providing services and billing for them. So think physician assistant, certified nurse midwife, nurse practitioner. Those would be other qualified healthcare professionals. So when we think about our practices, unless those types of providers are practicing in our clinics, the large part of what can be counted in total professional time is going to be the doctor's time and the time that we're spending on care of the patient on the day of the encounter. So that could include preparing to see the patient, obtaining a history, performing the exam itself, counseling the patient, ordering medications, tests, procedures, referring and communicating with other healthcare professionals when not separately reported, documenting in the EHR or paper, interpreting the results of special tests, and very important in parentheses here, when not separately reported. We're going to go through an example of that in a second to call out why that's important. And then care coordination on the bottom. So I think those ideas sometimes can be made a little clearer just by talking through a few examples. Let's say we're seeing a new patient. The new patient checks in, takes 5 minutes. They go back, they're taken back by the technician for pre-testing. Maybe that takes 10 minutes. The doctor reviews pre-test data, whether that's in the exam room or in their back office. Let's say that takes 5. The doctor examines the patient, that takes 20. And then the doctor transitions the patient to an optician for frame and lens selection. Now, you could very easily say to me, well, a 99,000 series visit, in my practice, that would never result in frame and lens selection. That's okay. That's a little bit beyond the context or the point here. What I was trying to do is get elements of an exam of any kind that may be able to be tracked here so that we can highlight that only 2 elements of this are included in total professional time. The patient's time with the front office team, the patient's time with the technician, the patient's time with the optician, those are not elements of total professional time. So in this scenario, there's 25 minutes of total professional time. We would take that to our new patient table, and we would see that is a level 2 or 99202. Note that we are not paying any attention to case history and physical exam elements here, right? We're not counting up, yes, I did VA, IOP, visual fields. That's all not part of how code determination would happen next year beyond the time that it may take to do those things. So that is a new patient. Let's look at a little more involved wrinkle here with an established patient. Patient checks in again, they work with the technician, the doctor reviews pretest data, the doctor examines the patient. Let's say during the course of the exam, the doctor identifies a retinal lesion or something that requires or that the doctor feels that she would like an OCT for. So the OCT is ordered, technician performs the OCT, the doctor interprets that OCT and adds code 92134 to the claim. The doctor then writes a letter to the primary care physician summarizing the findings and what she plans to do about it. So the trick here, or the potentially confusing part, relates to the OCT itself. And the key part to point out here goes back to that list that we looked at a second ago, where in parentheses said, when not separately reportable. Because when we think about what the CPT definition of most special tests that we order is, we're going to see the words interpretation and report in that, right? That's very true of OCTs. It's going to say with interpretation and report. So if we say that differently, the interpretation report is included in 92134, and therefore the time that's involved in that should not be included in the office visit itself. If we were to do that, it would actually be double dipping. So in this scenario, we have the pretest data, the doctor reviewing the pretest data, we have the doctor examining the patient, and we have the doctor writing the letter to the primary care physician. That took 25 minutes when we add it all up. We take that to our established patient table, and we can see that fits in right on the level 3 range. So that's how that visit would be coded as 99213 if they were to code it based on time. Now, your EHR, if you're using one, may offer you a number of tools to help you. What I wanted to provide you with for context and for reference was just some ideas that RevolutionEHR has to help its doctors And what we did is we added an encounter timer that can be start and stopped as desired by the clinician, to allow them, uh, obviously, to start and stop it. So if they had to leave the exam room, perhaps they got up to a point of dilating the patient, left the room for 10 minutes, right? The being able to stop it allows them to restart it when they come back in later. They also can manually adjust the time, whether there's an error involved or they wanted to factor in time that was spent outside of the stopwatch sort of system. That feature will actually be preference and permission based, meaning if a doctor never saw themselves using time-based coding, they could turn this off so it never appeared there and it never bothered them in any way. On the flip side, if they thought they may use it from time to time, they can have that available, but also control the types of clinicians or the type of team members that can interact with it. So they could actually say, I don't want the optician to be able to start and stop that timer. So that's the timer. And then we also have to modify the auto coding system. We know in the current day, auto coding considers case history, physical exam, and medical decision making. That's not the way it's going to be next year. It's going to be professional time or medical decision making. So we've rebuilt the auto coding system in RevolutionEHR to consider both of those approaches. And the strength of that, or the power of it, is by presenting both paths to the clinician, we can allow the doctor to see the path that might allow them to be reimbursed more appropriately for their care. In this example, there were 16 minutes of professional time that equated to a level 2, whereas the low degree of medical decision making equated to a level 3. So the doctor could make a decision here based on, as I said, which code would potentially reimburse them better for the services that they're providing. Finally, we're going to obviously make it easy to get that information onto anything that would need to support the doctor in an audit. You know, in the present day, that if an audit happens, basically the form that takes is you'll get a request for a bunch of records, and you're asked to print those out and a lot of times fax them or upload them to a secure portal. And then somebody on the insurance team will actually sit down at a desk and go through those encounters and code them, right? They'll look at the elements of the case history, physical exam, and MDM, code it, compare it to how you coded to determine the accuracy of your coding. Again, that's not how it's going to be next year. So audits will need to change shape. And when a doctor codes an encounter based on time, the only way an auditor is going to be able to verify that the proper code was used is if there's documentation of that in the medical record that they're reviewing. So we tried to account for both scenarios, if there was an in-office audit or if there was a desk audit where records were sent somewhere. So we're going to preserve that time in the header of the encounter as well as make it available on the encounter printout. This encounter printout detail will actually be preference based as well. So if someone didn't want it there, but wanted to turn it on in audit scenarios just so the time could be represented, that's something that they can do. So those are the tools that Revolution has available. Again, if you haven't communicated, or more likely if your vendor hasn't communicated directly with you on this topic, now would be actually a great time to explore how they may be supporting you in those areas. So if we summarize the whole coding topic, remember that E&M coding, 99,000 is changing on January 1st. The 99,000 series office visit code selection is going to depend on either professional time or medical decision making. Remember, we said case history and physical exam still very important parts of an exam, but you should feel free to document those as clinically appropriate. MDM, the guidance there is virtually unchanged. As I mentioned before, just some descriptive changes to help people understand the levels a little bit better. On the time-based side, though, it's a pretty new concept. So it's going to require consideration of all time the doctor spends on management of the case on the day of the visit, unless it's included in other codes that are utilized. We talked through an example with an OCT where the doctor coded OCT, like 92134 in our example. So the time that was involved in the interpretation report of that would not be included in the office visit. And we talked about the tools that RevolutionEHR would make available to help their customers in January. Obviously, there's a little bit of a trick there in that it needs to be available in January, but can't be available now. So all these things are sort of sitting in the background waiting to be turned on by our product team. So I hope that was helpful. Looking at the clock, I see we came in just under 45 minutes, which was our estimate. That's pretty good. I have been asked to launch a poll here at the end. I'm very happy to talk through questions that are out there, so we should feel free to do that, Tracy and Marnie. But I've been asked to launch a poll. just related to RevolutionEHR itself. And if anybody would like more information to talk to anybody on our team about how RevolutionEHR may fit into the practice, please feel free to request it through there. Keep in mind, you're not signing up for RevolutionEHR. You are not committing to anything beyond a discussion about how it may be able to fit into your practice. So with that, how do we do on questions, Tracy, Marnie?
Hey, Brett, not too bad at all. Although I have a good one that I think other people might be wondering to themselves, is the discussion on the 99,000 codes applicable only to Medicare, or is the intention that the 99,000 codes apply to the commercial insurance space as well?
Yeah, it is. That's a great question. Understand that that is CPT moving forward. So in theory, all payers should be following CPT. Now we know that some payers like to create their own rules, so we may need to sort of, as I mentioned before, I think you use the terminology, sort of keep our ears to the ground and figure out exactly what each payer wants. But personally, I intend on going into 2020 believing that all providers are, excuse me, all payers are going to be following those rules since they are officially CPT. They've been formalized by the AMA and CPT. So that is what we should expect, in my opinion.
Perfect. Other than that, oh, here we go. Every time I'm about, that always happens, right? I'm ready to say we don't have anything else. So if I work with occupational therapy, do I include their time under the billing time?
Start that one again, Tracy.
So if I'm a provider, but I work with occupational therapy, or I'm assuming what they mean in conjunction with an occupational therapist, do I include their time, the therapist, um, under their billing time? It got a
I,
little confusing at the end. So
yeah, that may be a good one to reach out through email just to make sure that I'm understanding the scenario.
yeah,
So maybe that's how we'll tackle that.
there we go. I'm going to give everybody just a second because something always pops up at the end, but I think we're kind of ready to wrap this up.
Great.
All
Well,
right, nothing new coming in.
Okay, great. I'll close the poll, and I will say thank you to everybody for your time today. As I said earlier on, if there are any questions at any point about this material or anything that I said, please feel free to reach out. My email address is on the screen. Be very happy to talk about it anytime. So with that, Tracy, assuming that we don't have any additional questions, we'll sign off and say thanks again.
Thanks, Brett.
Yep. Thank you.